Good evening, everyone, and welcome to the ERN-RITA webinar on transitioning from childhood to adulthood and recommendations for primary immunodeficiencies and autoinflammatory disorders. This is the second webinar of a series of patient-centered webinars which ERN-RITA has organized for this year. Thank you for tuning in tonight. My name is Michael, and I'm a patient representative from the support group Rheumalis in Austria.
Hello, everybody. My name is Camelia from HAE Junior Patient Organization in the Czech Republic. Both Michael and I are RIPAG patient representatives. RIPAG is the patient representation in ERN-RITA. We are thrilled to be your moderators for today's session.
Okay, before we begin, we want to extend a warm welcome to all the attendees. We're very delighted to have you here today. If you have any questions at any point during this webinar, please feel free to write them into the chat box. These will be answered at the very end of the webinar once both presentations have been completed. Today's webinar is also going to be recorded and will be available for replay on the ERN-RITA website. These new patient-centered webinars are aimed at healthcare professionals, rare disease patients, caregivers, and also the general public. The topics have been carefully selected based on feedback, and they cover all of the 4 disease streams represented by this network.
After this short introduction, we are ready to start with the webinar on the topic of transitioning from childhood to adulthood and recommendations for PID and AID. Let's welcome our speakers, Dr. Pere Soler and Dr. Mojca Zajc. Our first speaker, Dr. Pere Soler, is a PID expert from the Children's Hospital Vall d'Hebron in Barcelona, Spain, a center of expertise that is part of the ERN-RITA network. Pere, thank you for joining us today. Please go ahead.
Thank you very much for this kind introduction. Just let me try to share my screen. Does it work? Can you see it full screen?
Yes, we do.
Yes. So thank you, Camelia and Michael. I mean, it's my great pleasure for being here, especially in this kind of webinar, which is not only focused on physicians and nurses, but also on patients and general population, which I think is key, mainly in rare diseases. I will give a short talk on transition from pediatric to adulthood for patients with primary immune deficiency, which is one of the 3 streams of the ERN-RITA. So the question is, why do we have to talk about transition? I mean, is it an important issue or is it not? I mean, we all think that it is, and in fact, you will see that in the last 2-3 years, a lot of papers have arisen from different areas in the world, both Europe, US, Eastern Asia, as I will show in my following slides. And we all agree, despite obviously the strength is just based on expert opinion, that with a high level of agreement, transition of care is critical to make sure that long-term follow-up for patients with primary immune deficiencies or erosive immunity, and that allows the best management of those patients over time. So that's the reason why we are focusing on that topic today. So just let me see if it works. Yes. So to check that, we need to know where we are, and this is data from the US, AAI, and CIS. They perform a survey that was also recently published, as you can see in the bottom of my slide. And what is extremely important is that around, despite the number of respondents was quite low, as you can see also in the slide, a significant number of them said that they were no transition policy on their center, and they would like to develop one, but something needs to be done in the US, as shown here. If we move to Southeast Asia, things are not that different, and a lot of centers reported the absence of transition guidelines, the absence mainly of adult specialized center, which is quite common worldwide. And then moving to Europe and moving to the ERN-RITA transition working party that I'm co-leading with Siobhan Burns. Here you can see that despite the number of respondents reporting that they do have a well-defined transition process, there are still some that say that not, both in the PID stream and the AI stream, autoinflammatory disorders. And what I think it's more important is that they all agree that there's a lack in national or international guidelines for smooth and appropriate transition for these patients and also their families. And what I will talk about is the way that we are facing this problem or this issue in our hospital, which is a reference center both for pediatric and adult AI patients at the regional, national, and international level. I think that this is an extremely important point, because if you are working in a monographic pediatric or adult center, things may be quite different, and we can talk about that at the end of the presentations. And we are following more than 1,300 patients, both children as adults, as I mentioned before. And since 2021, we created a well-established transition program for all rare diseases, including primary immune deficiency. Sorry, it's called SOMI. That means "Let's Go" in Catalan. And we, in terms of primary immune deficiency, we are transitioning around 6, 8, or 10, depending on the year, individuals to the adults units. The first thing that I would like to stress is that it's a nursing role. I mean, at least in our case, it's extremely important. We do also participate as physicians together with the psychologists, social workers, at both sides, both at the pediatric side and then the adult side. But at least in our hospital, the one who's leading this project is the nurse, the practitioner nurse that is taking care of these patients since they are young and they transition to adult age. And we have already created all these documents and all these protocols with an active patient's participation, and every 3 years we do check its functioning with our patients association. How does it work? I mean, it's focused on children, in teens and young adults. I mean, it doesn't stop when you have already transitioned the patient to the adult departments. Obviously, you need to keep on following those patients as part of the transition program for 3-5 years to make sure that everything goes right. Obviously, it's a multidisciplinary process. As I mentioned before, there are a lot of actors there, and the nurse is a key one. And we have adapted our transition process depending on the complexity of the clinical case. As we are reference center, there are different transfer destinations. It can be our own hospital, but also other hospitals, and in very few cases, mainly those that are the mildest ones, they can even be sent to the primary care, but that's not happening that's commonly in primary immune deficient patients. On the other hand, we do receive teenagers from other hospitals that join our adult services, because there are few adult units for primary immune deficiencies in Catalonia and in Spain. As I said before, there's a role for primary care to have this shared follow-up, mainly for adult patients. We do need this individualized care. We are including the use of telemedicine to make sure that mainly when they are adults and they are working, we can keep them under an appropriate follow-up. And as I said at the very beginning, we do also have an important participation of patients, associations, and foundations. It's not only for primary immune deficiency, but for all the rare diseases. With this slide, the only thing that I want to show is that it means a change. So the change means that you can find some resistance, you can even have chaos, and then you need to come up again and turn to have this normal follow-up during adulthood. We all know that care for adult individuals in any hospital, I think, is less structured than what it is in pediatrics. So there's an extra effort to do for rare diseases to keep this kind of appropriate follow-up when they are sent to the adult units. So to do that, you need to identify problems, and it's not only our job in terms of physician, it's healthcare professionals, but also the patient itself and the family. And with that, we need to prepare, we need to plan, and then we need to implement to make sure that this change process go as smooth as we can. So I will just talk about the pediatric side, but I'll be happy to take questions on the adult side, because I'm also leading the IAI committee in our hospital. On our side, we are 3 pediatric immunologists fully dedicated to primary immune deficiencies. Obviously, other specialists will take part of this transition process as requires. I mean, and again, this will depend on complexity, as I will show in my following slides. The role of the nurse practitioner has already been mentioned. We do have a fully trained psychologist for primary immune deficiency that it's paid by a private foundation collaborating with us, both in the pediatric side and also in the adult side. And the role of the social worker is extremely important to make sure that everything related to work absenteeism and so on is well resolved before we are asking the patient to do an appropriate follow-up in the adult units. So as I said before, we have different approaches depending on case complexity. So in very few cases, those mildest one that I mentioned before, you can even just ask the basic healthcare team to do this kind of transition. That would be the physician and the nurse. But what it's more common, it's the green box that you can see in the middle of the slide, is that you need this multidisciplinary team for patients with primary immune deficiency with the little role of the nurse that I mentioned before, and all these guys taking part of the project. It's true that in some diseases, and that's not the case for primary immune deficiencies, because we do have a well-defined reception in the adult units, is that the hospital has a transition team that picks up all the patients that are transition from well-defined pediatric units to less well-defined adult units. So that happens in some cases with most complex PID patients that also have, I don't know, neurological problems and a lot of other issues related to non-immunological manifestations of their disease. But as I said before, the green box perfectly shows what we are currently doing with our patients in terms of transition. So with that said, what I did to prepare this presentation is going back to my team and even some patients that are related to the Patients Association and ask them what were the key points for a smooth transition. And they said that they were 8, starting early, but there are pros and cons, as you can see here in the slide. Adapting transition to patient social reality, which is extremely important. We do have around 18% of immigration here in Catalonia nowadays. So you need to actually adapt this transition as the whole healthcare for these patients and families. Joint visit between adult and pediatric specialists are extremely important and well recognized by patients and the families. The roles of the nurse, psychologists, and social workers on both sides, as I mentioned before. How to approach to this multidisciplinary committee that I already spoke about, and having local, national, and European guidelines. As you can see, we do have local guidelines. We don't have national, let's say Catalan or Spanish guidelines, but we do already have European guidelines that will be soon released in a publication, as I will show you in my last slides. The role of patients and their families to develop and update those guidelines is key, and creation of supportive documents. I will just focus on these 3 points that I mark on the left side of the slides. I mean, it's the first time that you hear that transition needs to start when a patient is 12. It sounds quite crazy, let's say, but it doesn't mean that you need to tell them, well, at some point you will be moved to adult units, because they get stressed by that. But it's true that you need to start discussing that point with the families. You need to prepare them, to educate them, and at some point when they are 14, 15, 16, start assessing the skills to make sure that you can plan an appropriate transfer when they are 18. We do transfer our adolescents when they are 18, with the condition that the disease is quite stable for an appropriate transition. So then you have a couple of years that we call transfer years, because transition is not only transferring, and the following 3 to 5 years that I mentioned before is to make sure that the patient is well integrated in the adult units. This is an example of the different types of complexity that I mentioned before, and with that, the number of healthcare professionals that are involved in transition. Most of primary immune deficient patients are in this high complexity with light blue that you can see in the middle of the pyramid, but some of them may do present some other complications, mainly related to some previous infections or sequelae related to the disease itself, and then you actually have to include more and more specialists and look for the appropriate way to perform this transition. What we did in our hospital is we create some specific documents. Also, I mean, we do all have this transition protocol, but which I think it's extremely important is that we have questionnaires, and mainly we have patient report experience measures to make sure that we are doing things the appropriate way, in addition to this every 3-year meetings that we have with the Patients Association to make sure that it works. We had a dissemination plan to make sure that every physician and every nurse was aware that this protocol and program were available. We worked with our ICT to make sure that everything could be collected in the medical history of the patient, to make sure that may the patient move to another center, all this transition process is not lost. And as I said before, we do have this transition team, which is not usually used for primary immune deficiency, but it is for other rare diseases without these well-defined adult units. This is the protocol, again, with the name SOMI that I mentioned before, and we have created all these leaflets. Those are in Spanish. We do also have in Catalan, and we do have some in Arabic, because we do have a lot of patients coming from North Africa, and that's what we give them at different points of the transition process to make sure that they can read it home and comment to our nurse or to our psychologist when they come back to the clinics. These are more detailed information. And what I want to end my presentation with is, as I mentioned before, together with Siobhan Burns, who is the main leader of the transition working group of ERN-RITA, we work on an expert consensus using Delphi method. We scope all the literature to see what was available, and we draw some recommendations that were shared with other specialists, as you will see in the next slide, to create a recommendation at the very end, create guidelines that will be released and sent for publication next month, hopefully. So you'll be able to read it soon as a paper. So we start with the IPOPI PID Life Index website. So the survey was sent to all centers in Europe, and we have not a bad response rate, around 41%, 68 centers in 22 countries, which I think is quite good in Europe and some other countries. We had pediatricians, but we also had adult physicians, and we also asked our colleagues from the INGIT, in terms of a European and International Nurse Association, and a small group of psychologists to analyze and be part of this Delphi project. So we start working on 2021 with the first survey, and we did the second survey on 2022 and 3 to those who were initial responders, and we agreed that only those statements with a level of agreement of 80 or greater were accepted. As I said before, the manuscript is written, and in fact this will be soon released as a full manuscript. And with that, I'm done. As I said before, I'll be happy to take the questions at the end of the webinar. So that's it. Camelia and Michael, the floor is yours. Thank you.
Thank you, Pere, for this excellent presentation. I'm really heartened to see that so much thought and preparation goes into this process at your end, and hopefully we can extend these practices to as many patients as possible in the near future. Now I would like to introduce our second speaker, Dr. Mojca Zajc, pediatric rheumatologist from the University Children's Hospital in Ljubljana in Slovenia. This is also a center of expertise as part of RITA and Reconnect's European reference networks. Mojca, thank you for joining us, and the floor is yours. Thank you.
Hello. I'm not sure if I already have the possibility to share my screen. So can I share my screen? Okay, so do you see my presentation now?
Yes, we can see it.
Okay, so hello also from my side. As I said, I'm coming from Ljubljana and we are the ERN-RITA and also Reconnect Center. So we are dealing with immunodeficiencies, with autoinflammatory diseases, but also with connective tissue diseases. So I will just start. So I will talk a little bit about the transition of children with all different immune-mediated diseases. So this is the overview of my presentation. First, we'll focus a little bit of our diseases and our patient. Then we'll start with the basic vocabulary of transition and what is the fuss about transition now, and what is the status of transition right now around Europe. And then we'll just check the transition activities across the ERN network. So inborn errors of immunity and other immune-mediated diseases. If we just take a look of inborn errors of immunity, this is almost 500 of different disorders. They are genetic and they show its poor or absent function of immune system. So the majority of these disorders manifest themselves in childhood. And so historically, they had a very, very bad natural course, so very high morbidity, very high mortality. But lately, so in the last decades, early, mostly genetic diagnostics and also the treatment changes that are now available to the patients have managed to bring really increased survival and improved life expectancy. So this actually brought the need for adult services and for adult specialists that previously didn't even know these patients because unfortunately they did not reach this age to reach the adult doctors. And on the other side, we have autoimmune and autoinflammatory diseases. So this is very, very different, a very big group of heterogeneous diseases, which are not associated with such high mortality, but they're highly impacting daily life. So they can bring a lot of disease damage and a lot of organ damage, a lot of functional disabilities. So what has happened in rheumatology in the last decades? This is actually quite an old slide that I'm showing to you. It's from 2015 paper, where you can just see this curve, how it's going upwards. So the number of novel treatments used in rheumatology is really, really increasing year by year. So the big changes in the treatment in the last decades, mostly with the biologics and with the small molecules, brought really higher demands from the patients how to be treated, and also needs for specialized adult services. So the adult specialists that would really, really know also the pediatric counterpart of the diseases, not just the adult diseases when they would maybe even change the name of disease, but they would have to be specialized in our pediatric rheumatologic diseases. So now we have like this influx of patients that previously didn't come or were not so demanding. And these patients are adolescents and young adults, and they are demanding by themselves. They're very special patients. You know, when the child gets very sick, parents have the key role in managing the disease and also managing other aspects of their life. We are all aware as physicians that better outcome comes with more involved parents. But when these children grow up, sometimes the control of the parents is quite difficult to let go. But these children want to become independent. They sometimes want to also be a little bit rebellious. So we are somehow headed for a clash with them. Adolescents are very different in their minds. They don't function as other patients that we know do. They say that the adolescents are the only patients that we meet as doctors that have very different values and priorities than we do. So we as doctors, we are thinking about the long-term outcome, we are thinking about keeping them healthy, and they're not. They're thinking about not having a disease. They're thinking about not living in the moment. They're thinking about their looks. Like all of us rheumatologists, we have met those teenage girls who don't care about the fact that maybe their kidney will not be working in 5 years, but they're just not willing to take those corticosteroids because they will make her look ugly for a while. So a huge number of these patients is now coming to a new doctor with whom they don't have a long-standing, trustworthy relationship. So what we're headed for is a very risky fact. The facts about transition to adult care are not so good. We know there are very high risks involved. The children and these young adults transferring to adult care are known to be not very good patients. So a lot of non-adherence to medications, a lot of loss to follow-up happens exactly in this risky period. So this all brings relapses of the diseases, which is associated with adverse consequences, with morbidity, mortality, and also all the social, educational, psychological outcomes are affected by this relationship that is not completely built when it's already beginning to be broken. So we as physicians, the last decades, we have focused on the fact that now we are able to somehow make these children better, now to somehow cure them, at least somehow with the use of a lot of new drugs. But now we need to keep these children and these young adults happy, healthy. So now we are focusing on transition, and transition is a purposeful, it's a planned process that addresses the medical, the psychosocial, and the educational, vocational needs of adolescents, and recognized adolescents and young adults with chronic physical and medical conditions as people that need very individual principles as they move from child centers to adult-oriented healthcare systems. And probably the most important step in transition is that you need to somehow achieve a psychological shift where the young adult becomes responsible for their own care. So psychologists say when a child gets sick and the mother is largely taking over and managing the disease, they don't really identify with their disease. So the disease is something that is outside of them. And with the transition, they need to become responsible for their disease. They need to somehow identify more with that and know and manage everything associated with that, because that's associated with the best outcome. And what is a transfer? Transfer is just the end. It's just the physical move of care to adult services. So it's just the last step. So this slide is from one of the most important and first publications about transition from adolescence to adulthood. It presents the 6 core elements that are still used in all transition policies in all different medical fields. So the one is that you need to have transition policy. So you need to build it, and then you need to track and monitor it. And you need to do all these things on both sides, so on pediatric and the adult side. And then you need to assess the transition readiness. You need to see if you've done well enough, if the patient is ready when you're transitioning. And of course, the transition planning needs to be integrated also into adult approach to care and practice. Then, of course, the transfer, and then the transition completion and ongoing care. As Pere said, this is a longer follow-up where you still want to know that your patient is doing well even when he's already at the adult services. So what is the status of transition in inborn errors of immunity and other immune-mediated diseases right now? Well, the first study that was performed on rheumatic patients was the study on juvenile idiopathic arthritis. And this was actually a study that was initiated by patients, because we see that actually the patients are the one that felt this need to make the transition process smoother even before us doctors did. So this was a study performed by collaborators from the SHARE project, from the PRESS and the ENCA Society. And it was the first study that actually addressed also their experience with transition. And what happened? Well, more than 600 patients with GIA and parents and caregivers completed the study. The mean age of patients was around 10 to 11. And only 10% were aware that transition even exists. So we need to raise awareness about transition because this was, I know, like quite some years ago, so 6 years ago right now, but patients were not aware of transition. They were not aware that there's any protocols, that they should be maybe somehow already doing something by themselves as well. So around at the same time, our cover organization, so the EULAR and the PRESS, published the standards and recommendations for the transitional care of young people with juvenile onset rheumatic diseases. So they published 12 statements, 12 recommendations, with a different grade of recommendation and a level of evidence, and mostly it was the expert opinion. So they all agreed that all patients with juvenile onset rheumatic disease should have access to high quality and coordinated transitional care. So yes, the transition process should start early as possible. So in these standards, the ideal age is 11 and the age 14 is the latest. And why? Because we need to allow the development of self-care skills, which does not happen in a year or two. It does not mean that your patient will be transferred soon. But for example, in our practice, this means that maybe at 12 or 13, the patient comes into your room to talk with you by themselves. And when you start to question, when you start to take history, when you ask them, have you been taking your medications? Do you need new recipes? Do you need your prescriptions? And this is when they see that they actually are not aware of many things around their disease. So when you stop, when you do a whole examination just with the patient, then you invite the parent in. This is how we do it. And then you do it all over again. So at the beginning, it really takes you twice as much as the time. But you see that when they are like 14 and 15, they are really managing a lot of the disease by themselves already. So the third statement is about the direct communication, so between the key participants. This usually means the adult and the pediatric rheumatologist, and usually this means a joint clinic of any form. So this depends, of course, on the availabilities that a certain center has, but it can be a clinic where both physicians physically attend. We also know there are some centers who have a virtual attendance of the other physician, but it can also be just a talk among the physicians without the patient present. That also, of course, depends on the complexity of the patients. And then transition process should be carefully documented. This should be for the young person and their families, but also for the healthcare professionals, so they can also recheck and reevaluate their transition program. The transition policy should be well written. There should be a transfer document with all the important documentation, with all the information needed at the end of the transition. And of course, as Pere already told you, this is a multidisciplinary team approach. So all the physicians that are involved, all the healthcare professionals, the social workers, the psychologists, maybe the physiotherapists, they're all involved in the transitional care. This depends on the complexity of the patients, and of course it's left to individual, so the physician can base the judge who needs to be involved with every individual patient. And then the healthcare teams should have appropriate training. So this is quite important, but also quite lacking, we feel. And because, as I said, patients were actually the ones that were aware of the what were the flaws of transition programs around before the physicians were. We feel that appropriate training is really difficult to achieve. And through the ERN-RITA network, we are actually organizing a transition course for healthcare professionals in Ljubljana in a year or so, so in the beginning of 2021, probably, 25, sorry. So the EULAR and PRESS didn't just limit themselves to medical recommendations. We know that the psychosocial aspects of transition and of the adolescents are actually their 8th vital sign. So this is maybe even more important. So there is this acronym that every physician could really easily memorize. It means like, let's getting into adolescents' heads. And it addresses like all the topics that you should talk about with your young adult, with your adolescents, before you're sure that he's ready for transition and that he's doing well, so that everything is somehow at peace when he's doing this important step. So one is like home, if anything special is happening there. So education, exercise, eating, especially eating disorders are quite common. Then the activities, the ambitions that they have. This also means if they want to go study somewhere else abroad, or do they want to know if their disease is compatible with the job they want to acquire. And of course, the big and important thing in adolescents, drugs and alcohol, you need to be prepared to talk about this, and also about sexual health, about contraception, about relationships. Then suicide and mental health. These are more important. We know that the mental health issues are very high among the priorities of the European Union right now, and also on other healthcare systems, because this is where we are lacking right now. So we need to be very sensitized to mental health issues. So sleep, of course, safety, and the social media. These are the ones that they suggest to talk about, and of course, the psychologists and social workers are the ones that should somehow work with you hand in hand in these ones. So the RITA network, as we know, is involved with primary immunodeficiencies, with autoinflammatory disorders, autoimmune diseases, and pediatric rheumatic diseases. Somehow the press and Euler covered the autoimmune and rheumatic diseases. And as Pere told you, the Siobhan Burns is the chair of the Transition Care Working Group, which was established to also somehow see the landscape of transition also in inborn errors of immunity and autoinflammatory diseases. Here is the manuscript that also Pere mentioned. This is to see what is the transition practice right now around the Europe. And it was quite a broad survey, which showed that most of the patients are transferred to some sort of adult center. But as Pere told you, the somehow disease-specific guidelines are missing. Most people just use some sort of local guidelines that they made by themselves. Again, what was seen in the survey, that the age of the start of transition is quite high, so the transition is probably started too late in most of the centers, and here we can probably have quite a lot of work that the recommendations that will be published are implemented. So what are the current transition activities? Well, this is how the results from the survey joined with systematic literature review and the Delphi process finalized the set of statements, which are now submitted and will be probably published soon, where recommendations will be available to everybody to somehow try to implement at their center. We are also member of the ERN-RITA, so this is mainly adult centers dealing with rare connective tissue diseases and musculoskeletal disorders. So the transition task force there is led by Taddeo Chin and Professor Gabriele Simonini. And we also performed the transition of care survey with the healthcare professionals. It was done in the winter. So Eduardo and me, we actually are just now doing the analysis of the preliminary results. We can see that even though we have some recommendations, they're not very implemented in practice yet, so still quite a lot of work. But we have received around 70 answers from almost 20 countries. So right now, which is also important for you, we are disseminating this survey for patients and caregivers, so you can also, the patients, give your opinion of the transition right now. So the next step are also recommendations from transition for rare connective tissue and musculoskeletal diseases. And of course, as I already mentioned, we are planning a transition, a course in transition for healthcare professionals in Ljubljana in 2025. So in conclusions, I would just like to say that with early diagnostics and modern treatment, the prognosis for these very severe diseases is markedly improved, and it requires specialized adult services. Adolescence is a very special and sensitive period in any person's life, and this makes the transfer especially risky for non-adherence and relapses. So transitions should be purposeful, a planned, multidisciplinary process starting early so that you manage to make the psychological shift where the young adult becomes responsible for their own care. And transfer is then the physical move to adult services. The recommendations for pediatric rheumatic diseases have been published in 2017. They're not fully implemented based on the results of our survey. But if we just look at the inborn errors of immunity and autoinflammatory diseases, now the landscape is known and the recommendations are coming soon. So what I feel it's also really, really important, and that all of us that are dealing with transition, we need to raise awareness about the importance of transition. We need to raise awareness among pediatricians and also about adult healthcare teams, and of course the patients. And I think here the patient's voice is very, very important, because it leads to very good studies, and we also as physicians learn from you patients. So just really the last slide. In our survey, we asked the healthcare professionals to write words that they associate with transition, and this is the result. So responsibility, education, independence, but also difficult and fear. So thank you very much. It's all teamwork that makes everything better. Thank you.
Thank you, Mojca, for your insightful presentation. Before we begin with the questions and answer session, we would like to remind all attendees that they are welcome to write their questions in the chat box. And the first question is for Dr. Pere Soler, if he can address the first question. Dr. Soler, which are your key recommendations for other groups that they can implement to improve their transition process?
Thank you, Camelia. It will depend on the type of hospital they're working in. I mean, if they are working in a hospital with pediatricians and also adult physicians, what is extremely important is now that they are available, try to just adapt the European recommendations for primary immunodeficiency, autoinflammatory disorders, or autoimmune disorders that, as Mojca said, are established from 2017-18, so they are available, and with that they need to adapt them to their reality. It's extremely important, and since the very beginning everyone is taking part of this process, because it's not just the pediatrician doing the protocol and then sending the patients. It's the active role of adult physicians is important from the very beginning. Moving from a physician-centered model to a nurse and psychologist center model with an active role of the patients and the families, and with that said, start moving, and in a couple of years analyzing the results, asking the patients about the feelings about the transition process, and then trying to readapt that.
Okay. Thank you very much. Another question that could be addressed for both of you, but maybe Dr. Mojca Zajc could be the first one to go. How do you collaborate with patient organizations as part of the transition process at your clinic, please?
Well, at our clinic, we have quite a strong patient organization that is also part of INCA and of IPUPI. So we are right now, for example, we are having a Central European Rheumatologic Congress in Ljubljana in December, and we have a full session dedicated to transition. And for example, one speaker will be a patient, and also the patient organization will try to provide their view. So like at the moment, I think like the biggest problem for us is maybe cooperating with the adult care, as Pere said, like sometimes the recommendations look like the pediatricians are writing it, and then we are just sending it to adults. This is what you need to do. So I feel like the patient organizations are working fine with us, but we are very happy that they're starting to work also with the adult teams.
Thank you. How about you, Dr. Soler? Would you like to share with us your experience?
Yes, as I said during my presentation, when we first wrote the internal protocol, we shared that with a significant number of patient associations working on rare diseases. And after doing that, we work with our primary immunodeficiency association and a foundation that is located here in Barcelona. So they are actively participating in this process. And I said before, once after 3 years, we will again review with them whether this is working fine or not. And they are key for the process, because as I said before, the psychologists, both in the pediatric and the adult side, are already sponsored by the foundation. So it's something that was not available for primary immune deficiencies in our hospital, and they allowed us to have these key professionals for an appropriate transition of these patients, because it's not only being a good psychologist, but also being well trained in these rare diseases that are so heterogeneous. So they know what transplant is, what a primary immune deficiency is, the meaning of being under immunoglobulin replacement therapy, and so on. And that has led to a significant improvement in the care of these patients, and they are mainly focused in transition.
Thank you. The next question is from the parent side. Are parents still welcome during and after the transition period, and how should we be involved as parents? Whoever wants to take this one first.
I can take it. I mean, because it's extremely important. They are an active part of that, and we as healthcare professionals, we need to let them know that they are still part of that. I mean, it's not that they are not longer taking care of their kids. They are doing so, but in an appropriate manner. They need to leave the patient, him or herself, to be the main responsible of their health, and that's extremely important. But it's not just, it doesn't mean that you are not allowed to get into the clinics from the very beginning, but you need to, from time to time, wait outside, let the adolescent be an active actor of the transition process, and with that you will allow him or her to be a full responsible of the disease when they're, I don't know, 18, 19, or 20. But it's not a switch on off process. I mean, it's not that they are off of the care of the patient, of their son or daughter, but it's a progressive way. They need to allow the patient itself to be the main responsible of this job.
Yeah, I agree with Pere that the parents are never like kicked out of the room, but the transition, as we said, it's a process in the patient, but it's also a process in the parent where they need to somehow learn to trust their child as well. And sometimes this is also, you know, a very learning curve for the parents as well.
Thank you.
In fact, Camelia, here in Barcelona, what we did with the foundation is that we had a group of parents of patients who were in a transition process, and they met together with the psychologists to help them know what their role were. I mean, because it's not that you are, I mean, out of the process, but you need to know how to manage that, and it's not that easy, mainly for those patients that have been significantly ill during childhood, because they are very used to take care I mean, perfectly of their kids, but they need to realize that this transition process is as important as it was of being actively taking care of the kids in the previous years.
Thank you. Very, very interesting. With the next question, again, it can be addressed to both speakers. Which procedures or questionnaires do you use with your patients to check they are ready and have fulfilled all the goals for a successful transition? Mojca, maybe you would like to go first?
Yeah, I have to say that right now we are not using the official questionnaires. It's mostly physician-based assessment, which is based on individual patient when he has been following the patient for a long time. So we are not using the questionnaires in practice right now.
Thank you.
We're using questionnaires, and it's the nurse who is the main responsible to assess where the patient is. I mean, at what point of the transition process the patient is. And this is, as I said before, collected in the medical report of the patient, in the electronic health record, to see within couple 3 years, from 15 to 18, how things are moving. And as I said before, it's not just being 18 when you need to move your patient to the adult unit, but you need to make sure that he is in good position to do so. And as I said before, again, you need to recheck that the disease is at least quite stable.
Thank you. One more question. This one is for Dr. Mojca Zajc. Since the pandemics, the psychology teams across Europe have been facing a huge increase of their amount of work. And how do you believe it can address the current situation, the needs of the transition adolescents in this setting? Do you have experience with work in small groups?
Yeah, I think it's all about, as I said, that we need to raise awareness with transition. So, of course, if you raise awareness with your supervisors and with your hospital, then you will somehow be able to get psychological services. And yes, they are overwhelmed. I think, I mean, at least I can say for our part, more and more psychologists are trying to be trained, and more are needed. So I feel the mental health is actually the big issue now, and yeah, we are fighting for our psychologists, and we try to like all our patients have them, and they are specially trained to be dealing with children with chronic rheumatic diseases. And yeah, it's difficult, but you have to pursue this. We feel it's very important.
Thank you. And maybe one last question for Dr. Soler. What are your recommendations if the patient is clearly not ready for transition?
Just waiting and keep working. I mean, you need to see what it means. I mean, and if you do things right, they are usually ready for transition. It doesn't, and even for transfer. It doesn't matter that they're happy with that, but you need to check what it means. As I said in one of my slides, you may start with some resistance, and they seem to be lost at some point. But if this is true and it's not just fear, then you need to wait and keep moving, and make sure that once you've sent the patient to the adult hospital, he or she is ready, because otherwise you will the patient may be lost, adherence to treatment then turns to be worse, and final outcome tends also to be worse. So if it's not ready, and it's true that it's not ready and it's not a matter of fear, then you need to wait and keep working with the patient, and probably coming back to the parents together with psychologists to see what's going on in this case.
Thank you. This was the last question we had in chat. We don't have any other questions.
Okay, so that was the last question for today's webinar. Before we wrap up, again, would like to say thank you to our two excellent speakers and their presentations. It was really useful for us. And also thank you to everyone who joined us today. Please keep a lookout for the next installment of this patient-centered webinar series from ERN-RITA, the details and timings of which will be announced very shortly. Thank you for joining, and good evening.
Thank you. Bye.
Goodbye.
Thank you.